Hello, everyone. Dr. Nikhil Verma here with another edition of Things I Didn't Learn in Med School. I have a great episode today. I want to talk about Medicare Advantage plans and why they're not so advantageous. Um, it's a great episode. If you follow through this and understand what I'm talking about, you're going to kind of scratch the back of your head and be like, what is going on in medicine? How is this even legal? How is this a thing? Before I get started into that, I want to kind of just break down what Medicare is. So Medicare is a government subsidy program that helps pay for medical costs for individuals that are 65 and older. There's a pool of money. You contribute to it throughout your lifetime. So when you're at your retirement age and you don't have significant income, so instead of paying into a health insurance premium plan, the government is like, okay, you've done your duty to society. You're done what we've asked you to do, and you've paid your dues into this Medicare fund. So here's your retirement gift as medical expenses covered. Now the thing is, they don't cover everything. They do cover a lot of things, and there sometimes is associated about a 30% fee with the costs involved. So there's four, but really three major parts of Medicare Advantage or Medicare plans. There's a Part A, which kind of covers everything in hospital. So you go to the hospital, you get sick, you have pneumonia, you go to the hospital ward, they need to put you on a heart monitor because they know, so all that stuff, any imaging, any labs, that's all covered by Medicare Part A. Then there's Medicare Part B, which covers your outpatient services. That's any outpatient service. So you go to your primary care doctor, you go to a back specialist, you go to your immunologist, you go to your allergist. These are all the things that are covered in your Medicare Part B. And then Medicare Part D is a prescription service that helps cover cost of prescriptions. Funny thing is, they don't always cover all of it, which can leave a bind for patients to pay some money out of pocket, especially for expensive medications, especially the ones that aren't generic at this time. It's another topic for another day, but something to think about. Well, so you'll notice that I skipped Medicare Part C. Well, that's where I kind of was hedging my bet on this. 3, maybe 4, but let's bounce back to 3. Medicare Part C is this idea that the Medicare Advantage kicks in. So overall, what it means is that Medicare Advantage it covers A, B, and sometimes D by a private health insurance group. For example, Anthem or Aetna, Cigna, etc. They might have a Medicare Advantage program involved with their overarching insurance infrastructure. So you're like, oh, that's great. I can just pay into these, and they'll take care of my Medicare Part A, Part B, and Part D. Well, not so fast. First, the most important thing to think about is that, in neither one of these, in Medicare regular or Medicare Advantage plans, you're not paying a premium. Some premiums can be somewhere around $100 to $200, up to $500, up to thousands of dollars for your premiums alone. You don't have those in these programs. Similarly, there's no copays. There's no co-insurance. There might be. I don't think there's any co-insurances involved. But again, you do pay about 30%. Well, here's what the tricky part about Medicare Advantage plans are. You have to go to the in-network doctors within that Medicare plan or Medicare Advantage plan. So if you go to Anthem, for example, you have to go to one of their in-network doctors. You can't pick and choose. There's a lot of hidden fees that are associated with it. You might have copays in these examples versus in the Medicare plans you don't. The other thing that could cause patients to get into trouble is denial of benefits. So they're supposed to carry the same guidelines that the Medicare program gives. The LCD guidelines, the local MAC guidelines. That's something that I will definitely get into in another video, understanding how that all works. But for all intents and purposes, for this video, just talking about Medicare, there's certain guidelines that Medicare requires for certain procedures or certain criteria to be met before you can do certain things for patients. If those criteria aren't met, then they can deny coverage for a claim. Again, I'll go over this in more detail on another lecture, but um, going back to this Medicare Advantage plan, so they're supposed to follow the same guidelines, but they don't always. So they might follow their own guidelines within their own um, insurances. So the Anthem that I was explaining, they'll cover what Anthem covers and not cover what Medicare covers. So that's something that can lead to some problems and issues for patients, especially because usually Medicare covers a lot more under the sun than these private insurers. Private insurance will often find things as experimental or as no data behind it or lacking solid evidence, or they say it's too new of a procedure. There's tons of reasons why they'll deny it. This is actually funny, not funny, it's ironic or kind of upsetting. Dr. Giuffrida, Anthony Giuffrida, just posted on Instagram yesterday saying the same thing. He's like, this is crazy that insurance companies are denying our patients care because they find something that's experimental. Yet we can come to them with 7-year data, 10-year data, and present this to them, say, yes, we understand that, but our company finds this experimental. And then we go to a peer-to-peer, and these doctors on the other side of the line say, yes, I agree with you. I think this is the right treatment for this right patient. But the guidelines from this insurance company says no. So think about that the next time you're trying to go through a peer-to-peer or trying to submit for a patient. That the insurance companies who don't have MDs, who don't have DOs, who probably aren't even in the science realm, but more business realm, they are dictating the care that you and I can receive, our family, our loved ones, America. So just think about that. I think we need to band together and find ways that we can find solid solutions to these problems so we can help more people out. All right, it's a little side tangent there. So going back to this Medicare Advantage information. So, right, so they can deny things. They don't always cover, so you can get, that will sometimes result in unexpected costs. And it can also just drop the benefits altogether for that entire claim. So that would result in the patient would be stuck with that bill. So some things to think about. Other things, you can still pay co-pays in these Medicare Advantage plans. Not always, but that's something to be thinking about. But the biggest thing, and the reason I want to bring this up, is because I wanted to bring up this very interesting article that came out in April of 27th, 2022. Now, it also was reiterated in JAMA Network in May of 2022. But this was a U.S. Department of Health and Human Services Office of the Inspector General. So this is at the federal level. They came out and said some Medicare Advantage organizations' denial of prior authorization requests raise concerns about beneficiary access to medically necessary care. So this is all coming full circle. What I was talking about in that tangent is patients that need the services, the proper services, backed by data, are not getting the procedures and the treatments that they need because these Medicare Advantage plans are denying them. This brought up a huge investigative study from multiple sources. I just want to pull out some points from this article. They're just saying that they sampled through 250 authorizations and denials and payment denials of the 15 largest Medicare Advantage organizations from June 1st to June 7th of 2019. And pretty much they found that multiple things, but overall, they were finding that there's just a bunch of denials and not true denials. The denied request would actually meet the Medicare guidelines, but they didn't meet these individual insurance guidelines. So in the old system, I will say, I don't want to say the perfect system or the better system because I don't know if that's true. The system of a Medicare plan, these patients would have got that procedure. So I'll just give an example of like an MRI. In the older system or the Medicare system, they would have gotten, but in this Medicare Advantage system, it got denied. Not only that, there are delays to treatment. they would need to delay for site of service approvals. They would have to delay for inpatient rehabilitation services. Um, the number that's popping out to me is 13% met. So that's quite a few claims that are getting missed out. Um, the other big thing that they found is the prior authorization request did not have enough documentation to support approval. That's what the insurance company said, but the Medicare Advantage plans, but through the department's review, they're like, yes, it does. We can highlight, circle, and point to the point where it did meet the recommendations. So not only were the Advantage plans saying delaying treatment and messing things up and denying it unnecessarily, but there were ones that they were actually met the criteria and they still denied it. So now you're starting to think is like these insurance companies are causing way, way more problems, especially for the patients that need the care that they need. So um, I hate when I get on these rants of bashing insurance companies as much as I do, but it does add to a significant amount of stress to uh, practice, to a hospital system, to a group organization, to whatever, but also for the patient. I mean, in the perfect world, if I was the czar, like give the patients the right care to the access that they need for a fair price. Um, you know, I was getting conversations today with some of my co-fellows, my old co-fellows, and a group that we have a little mastermind group with. That we were talking, and sometimes I feel like this patient that came to my door didn't get the services that they needed because that doctor just didn't have the tools in their tool belt. So there's something to be said about that. That we're all limited in the scope, in the echo chamber, in the dogma, as my mentor Bradley Goodman always says. We're kind of stuck in our own echo chamber of what we can offer for patients, and sometimes that's the only way we can see the world and the only way we can help them. I'm not ignorant to that fact. I do understand it, but I also was just thinking, it's like sometimes we should be offering the best services that we have for a fair price for our patients. And that fair price doesn't necessarily mean the patient has to pay, but if it's a Medicare plan or Medicare Advantage plan, allow them to pay and allow them to pay appropriately. Um, some other things that we found is that the study found that 18% of the requests met the Medicare coverage and the billing rules, but the denials were caused by human error. So it wasn't anything that was electronic. It was the humans doing issues in the Medicare Advantage plans, and they were the ones that were dropping the ball. And the systems at those Medicare Advantage plans weren't keeping up to the Medicare guidelines. So that's super interesting. Just 3 quick points that they recommended is issue new guidance of the appropriate use of Medicare Advantage clinical criteria. So get more online with the Medicare plans. Update the audit protocols to address issues, identify the reports, and direct Medicare Advantage plans to take additional steps to identify and address vulnerabilities. This could be as simple as an internal audit system to make sure that they're keeping up to guidelines, that they're helping the patients out appropriately, and that they're not overly denying causes. We have this running joke that insurance companies only interest is to deny care because, why wouldn't they? If they always had to keep paying for everything, then they would be broke. But if they can keep denying things and making it a headache for some doctors to get something approved, then they would bank that money in the front end. So I know it's a terrible way to think about the world, but that's the reality that we live in. So lastly, I did want to just talk about this JAMA network and some more numbers. About 26.4 million of all Medicare beneficiaries were in a Medicare Advantage plan. So that's a huge number. That's just under half of enrollees. One thing I should say that I hadn't said is that these Medicare, to be enrolled into a Medicare Advantage plan, you do have to be eligible for Medicare and you have to apply for Medicare. So that's something else to keep in mind. The last little bit here is these denying payment requests that met the rules delay or prevent the providers. I know I said this already, but I highlighted it again because I think it's an important point, or maybe I thought it was such an important point. I wanted to highlight it twice. Um, this is important stuff because we, as providers, we want to give care as healthcare workers. We all want to provide good care, valuable care for our patients. We want to do what's right. We want to do it speedily. We want to make sure that we're doing it appropriately. Um, I'm hard found to find a physician that does a lot of things atrociously inappropriately to make money. I think most doctors have a solid foundation, and like I said, an echo chamber that it might just be an echo chamber, and they only know what they know, and they can only do what they can do. But that doesn't necessarily mean that they're doing the wrong thing. There's still might be other things that they could offer or other things other providers could offer to help them out. But that doesn't mean that that gives these Medicare Advantage plans, these insurance companies, the right to deny care to our patients. Um, and I also wanted to bring to the attention of everyone is that these plans they look so good on paper when you present it to somebody in a retired state. It's like, hey, we got this excellent plan. You don't have to drop us as your insurance coverage. We will make a deal with the government and we'll get some money from them. And when we get that money from them, we'll cover your healthcare costs. But not only are they not covering the healthcare costs for the patients that are probably the most vulnerable, they're also pocketing that cash and making it harder for you to get the access care or the elderly to get the access care. So a little bit shorter today. I still hope you guys found it useful. Obviously, it's something that I found very WTF, what's going on with this. And I don't know if I have a solid solution right now. I think, as I said earlier, I think a great idea is for us as physicians, as groups, to start getting together, start thinking about great ways to talk about this. I know the American Spine and Interventional Pain Physicians, they have a great lobbying group. The American Academy of Physical Medicine and Rehabilitation, they're working on their lobbying and they're getting more and more. I know the Spinal Interventional Society as well. So these are some great organizations that we're starting to pick up steam. And I think we can realize that if something happens and they need the physicians and healthcare workers to band together, I think we can all get on the same page. And sometimes maybe just takes a leading voice to do that. I don't know who that leading voice is. I would love to find someone. I know it's definitely not me. That's not where my heart and passion is. But if I can maybe educate someone out there that could take the lead for us, I could definitely find myself advocating for that individual or a group of individuals and getting behind them and supporting them in any way that I can. So, anyways, again, I hope you start finding things useful. Please share it with people that you might think that this is useful. This isn't just for medical students or residents or fellows or people in the practicing world. This is probably information that you and your loved ones should know, your family members, your parents, your grandparents. This is directly affecting us at every level. So please share, drop me a comment. I've had a lot of people start reaching out to me, really appreciating this time that I'm putting into it. I'm having a good time doing this. I'm liking the conversation. It's actually sparked several students to reach out to me to ask for my time. I'm happy to give my time when available. It is getting a little time consuming to get on 3 or 4 phone calls a week, but I'm always happy to try to help out in any way I can. And same thing goes. I know I have an open door policy for any students or residents or fellows that want to come to Columbus and rotate with me and pick my brain about things. If you want more one-on-one time, I think that'd be the best bang for your buck, especially right now as I'm still trying to grow my practice and build some other things up. So anyways, hope to talk to you guys soon. Probably in the next episode, we'll talk about things you can do to leverage yourself in the private practice world. And also after that, maybe we'll get to that LCD contracts and the local coverages for the Medicare. Another topic is that I don't know quite how I'm going to do this, but I've heard of several things about how physicians aren't opening up the charts for patients before they go in the room, and they're like, "Oh, we should do this procedure for you," and the patient will stare them dead in the face and be like, "We did that procedure 3 months ago and it didn't work." So yeah, something important to talk about and think about. So anyways, I'm hoping you guys are enjoying this. Please share, please like. I'll talk to you soon. Take care.